So good evening and welcome to the latest BOMSS webinar, in which I'm absolutely delighted to introduce Professor Scott Shikora. Not only is he a Harvard professor and director of metabolic and bariatric surgery at the Brigham and Women's Hospital in Boston, Scott is also the editor of Obesity Surgery Journal, and he is the incoming president of IFSO, due to take over his presidency, I believe, at the Miami meeting in August. I first met Scott back in 2002 when Simon Dexter and I, both young surgeons at that time, traveled to Boston to attend one of the first laparoscopic bariatric gastric bypass courses, which was run by Scott and his colleagues. And we had a fabulous time. They really looked after us. And I personally owe Scott a great debt for sparking what has been a really great career for me in advanced laparoscopic bariatric surgery. Scott is a self-confessed Anglophile. He loves this country and he's a great friend of UK bariatric surgery. And he has been hugely supportive of BOMSS during the difficult transition from August over the last year. And I would just like to publicly thank Scott for that. He has been a massive amount of support for us in the background, and we are so grateful for that. So it's a great honor to have him present to us tonight. I'm sure you're all going to really enjoy what he has to say. He's a fabulous speaker. It's just left for me to say, if you do have any questions during the talk, then please post them on the Q&A tab at the bottom of your screen rather than the chat tab, and we will deal with those and see you all later at the end of Scott's talk. Over to you, Scott.
Thank you very much, David. Hopefully I can get my screen going without too much difficulty. Yes. It's an honor for me to speak tonight, and I want to thank the organizers of the meeting, Vinod, Sharif, and David, for not only inviting me, but for their friendship. And yes, I'm an Anglophile, and I love coming to England and hope to do more of it. I think this is a very interesting topic, and I want to jump right into it. You know, all of the bariatric operations we do are generally good operations and generally succeed, but not always. And somewhere about 20%, and I'm going to say probably closer to 30% of patients will fail to maintain meaningful weight loss. Over a span of a few short years after surgery, they start putting weight back on. The etiology was traditionally thought to be either the fault of the patient or the program. You didn't do something right, or the patient was non-compliant. But there may be more to the story, and that's what I dug into to put this presentation together a little while ago, with some of the physiology that goes on in the human body to put weight back on. So we can't always blame the patient for their behavior. Oops. So this is the Swedish obesity study. It's been going on for over 20 years. It's a small group of patients that were either offered surgery to treat their obesity or medication and diet and exercise. And needless to say, it was one of the first papers that demonstrated the superiority of surgery over non-surgery. But the reason I show it for this presentation is that regardless of the operation the patient had, look at the different lines of the surgical treated patients, they all start to rise again. And this is a phenomenon we see when we look at almost any graph of weight loss in the literature. Well, let's stop here for a moment. Firstly, we need to define failure. There's no standard definition that we all agree upon. Does anybody know where the greater than 50% excess weight loss number came from to determine success versus failure? It was from a paper by Randy Reinhold, and it was based on entirely no data. What he basically did was he just broke up his population into quartiles, 0 to 25%, 25 to 50, 50 to 75, 75 to 100, and he arbitrarily picked 50 as the cutoff between success and failure. Well, it may be relatively manageable to get to over 50% excess weight loss with the malabsorptive procedure, but some of the restrictive procedures can't play in the same ballpark, yet we put them all together, so that gets thrown out. How about weight regain, or how much weight regain? Lack of improved health, lack of improved quality of life. Should it be universal, or could it be different for each procedure or each patient? So right off the bat, we're starting with a problem that we can't define failure. And then we look to see, was the failure the fault of the operation, or was it the patient who failed the operation? Well, everybody knows that weight, one's body weight, is essentially the difference between the calories that they take in versus the calories that are burned. If a patient takes in more calories than they burn, they will gain weight. If they take in less calories than they burn, they will lose weight. And this is what this surgery does for patients who have bariatric surgery. A little bit more complicated than just that, because the factors that occur because of bariatric surgery. So for instance, hunger goes way down, and all of our patients talk about the lack of appetite. They have restriction due to the sleeve or a small gastric bypass pouch, or even the small pouch created by a band. There's eating intolerances. There is foods that they don't tolerate. They just can't eat them. And it's different from one patient to the next, but usually bread, rice, meat can be difficult. And then there's behavior. The behavior to want to be physically active, the behavior to pick a proper eating and eat the right foods. On the opposite side is what you have is your calories burned. And that's the physical activity as well as the resting energy expenditure, which is basically how much gasoline, or as you would say, petrol, is burned when your car is sitting on the driveway idling, or when the body is sitting in a chair like we are now, just sitting. How many calories are we burning? And that's determined by the amount of lean body mass. The more lean body mass you have, the more you burn. The same way a car that has a 6-cylinder engine might use more petrol than a car with a 4-cylinder engine. Well, we do know that pretty much all patients will eat more as time goes out after surgery. And it was determined that for the first year, the calorie intake is somewhere between 500 to 1,000 calories, but after the first year, it rises to 1,500 to 1,700 calories a day, and possibly even more than that. What this demonstrates here is the, if you look across the top line, that's the estimated energy requirements. That's the number of calories the body requires. And the TEI is the total number of energy taken in. And what this demonstrates here is that basically in all the categories, the energy measurement of how much energy was necessary is about the same, 1,800, 1,836, 1,838, and there's no statistical significant difference between that. But if you look at those patients that lost less than 50% of their excess body weight, number one, they took in a bit more fat, and although it's not statistically significant, it is trending in that direction. Possibly a larger series may have demonstrated that. But the groups that lost more than 50% of their excess weight loss took in less calories than their body needed, and that's how they lost their weight, whereas those that didn't do so well took in, and again, the numbers are a little funny, but took in essentially the same number of calories they were burning, and that's why they didn't lose as much weight. Is it always the patient's fault? No, of course not. But there are times the patients have experienced, let's say, a weak program, and particularly prior to the Surgical Review Corporation Centers of Excellence, this was not uncommon. The patient was not educated either in diet or behavioral issues prior to surgery. The consent forms were not as informed as they should be, so the patients were not told about taking vitamins, exercising, eating correctly. The operation chosen might have been a wrong choice for that patient. It's possible that surgeon only did one operation, such as bands or sleeves. The operations may not have gone well. The pouch was made too big, the sleeve was made too wide, etc. And also a lot of programs had very poor, if any, long-term follow-up. So in that setting, you put more of the blame on the surgeon and the practice than you do on the patient. And this is just a menagerie of some of the operations that have failed over time. And many of them look familiar, such as the lap band, The vertical banded gastroplasty was the precursor to restrictive surgery. The gastric wrap and clip are very interesting. The clip has kind of come back now. But the bottom line is these operations were not good operations. And these were given to patients because that's what the surgeon was doing or thought was the best thing for that patient. So those patients putting weight back on is not surprising at all. And this issue about a dilated pouch, a dilated outlet with gastric bypass, it's very possible that this was a result of a less than perfect operation, or this is what occurred over time with maybe a little bit of overeating and stretching. Same thing for the sleeve. The sleeve on the left is all dilated, particularly the proximal sleeve, as you could see, and the normal sleeve is more tapered. So yes, I said that you can't always blame the patient, but there are times where the patient's compliance certainly was not sufficient. There may have been a lack of commitment, and as you know, after a year or so, a lot of patients don't tend to follow up. Unrealistic expectations, they get disappointed, they don't come back to clinic because they didn't lose as much weight as they thought they would. Most of them want to lose 190% of their excess body weight, and that's not going to happen. Dietary non-compliance. Over time, the dumping syndrome, which in many ways prevents patients from eating carbs, really lessens to the point in many patients they could eat all the candy and sweets they want and not get symptoms. Patients do start to form maladaptive eating, where they go from eating high protein diets to eating a lot of carbs and a lot of calories. And it isn't uncommon for them to stop exercising. And I love this quote. This is from Barry Fisher. He practiced in the Las Vegas area for many years, recently retired, but it was one of the senior members of ASMBS. And he said, half of my patients take half of their vitamins half of the time. And I think that sums it up beautifully. And there are studies that have demonstrated that. In this study, 100 patients had Roux gastric bypass. They had good weight loss, but 56% of them over time gained weight, and it correlated with poor diet quality and sedentary lifestyle. So clearly, patient noncompliance. This is data from that same series, just demonstrating that caloric intake increases over time from less than 2 years to greater than 5 years out. It's not only that, but it's the choice change that occurs of what they are eating, where they're going to more snacks and sweets, they're going to more fatty foods. And not surprisingly, at 5 years, there was a 60% weight regain. 60% of patients had weight regain. Can non-compliance be lessened? Now, this is my own opinion, having been in the field a long time. You certainly, based on your experience, may have it differently. But number one, I think you need to be careful on who you select to have surgery, not just because their BMI is greater than 35, but because they demonstrate to you they understand the diet, the need for follow-up, what the operation means, what it does, and what are the reasonable expectations. They need to be educated. They need to be prepared by a multidisciplinary team of experts. I'm not an expert as a psychologist or a dietitian, so I need to rely on them. We need to perform the operations correctly, and I don't say that kidding. There are some times where the operations are very poorly done. We need to provide a strong long-term postoperative program that it keeps patients as active in the group as possible, and it can use a lot of different resources such as virtual visits to social media, which we take advantage of. Our patients have their own private Facebook page, support group meetings, and appointments for with the dietitian for follow-up on diet. Now, however, despite all that, we still won't solve all the problems of weight regain, because even in the perfect situation, the perfect operation, the perfect patient, we do know that the pouches do over time stretch. We know that the small bowel accommodates. We know that from the short bowel syndrome patients. I mentioned the dumping resolving and the food intolerance is improving, where a patient before couldn't eat pizza now can eat 2 slices. So, And in addition to that, appetite increases where they had minimal to no appetite before, and now they actually feel hunger and they eat. We also need to remember that some medications that patients take for other reasons can also promote weight gain, particularly the antidepressants. So it's important to know what other medications your patients take. Equal. Increase hunger, the pouch dilates, they can eat more. They can eat more of different things because their eating intolerances decreases, their behavior changes for a less compliant behavior, less physical activity, the resting energy expenditure goes down because they have less lean body mass and they're not as active, and lo and behold, they put weight on. And we know that the body weight is aggressively defended like a thermostat controls room temperature. And we know that if you weigh, let's say 100 kilos and you lose 40 kilos, your body will then neurologically and from a standpoint of hormonally, try to get you to put that weight back on because it assumes that's the normal for you, for your body. And here's some proof, this animal study, I love showing it. They took 4 groups of animals, I think they were rats, and they overfed one group, 50% excess. And as you can see, that group had what we would say would be very fat rats. Another group, they gave a 20% deficit of the diet, and that group, you could see, had skinny rats. Then in the middle were the 2 control groups. So then at this point, they basically put the animals on just basically whatever they want to eat, as much or as little. And look what the fat rats did. They all ate less and were going to lose weight, whereas the skinny ones started to eat more and put weight back on. So as you could see, they're self-regulating their weight to get back to what their body perceived to be their normal standard weight. And we mentioned most of this already, that this process can be influenced by things such as depression, dietary intake, the amount of exercise a patient does, and then the metabolic rates, medications, and if there's any anatomic defects like a gastric fistula, dilated outlet, dilated pouch, that can play a role. This is not on the exam, but just goes to show you that there's checks and balances between the various hormones, as well as the vagus nerve and possibly other nerves. So this is a very intricate process that the body does to try to maintain what it can see, what it feels is the proper energy balance. And many hormones play an active role in this. We know ghrelin is a powerful hormone for causing hunger to get you to eat more. Insulin also causes people to eat more, and these play a role along with the vagus nerve in this process. So after surgery, patients lose fat predominantly, but they also lose some lean body mass. And by doing so, they're reducing their resting metabolic rate. And this is data from my own program a number of years ago, when we took a group of gastric bypass patients and studied them preoperatively in 1 year. And the bottom line is that if you look down here, from baseline to a year follow-up, that total energy expenditure went down, and that was statistically significant, as did resting energy expenditure. What was going on here was they lost some muscle mass and they exercised less. So the energy expenditures, everything went down the same way it would be noted in a patient with starvation. So this is a model like the starvation model, where the body tries to conserve resources by shutting down some of its energy expenditure and total energy expenditure. And this is what it looks like if you kind of put it together in a pictorial manner. Less muscle mass, decreased physical activity results in a reduction of the total energy expenditure. And if the patient's still eating the same amount they were eating before, this would lend itself to weight gain. So what can we do for these patients? We can't just give up on them. I think we have to start from square one. We got to get them back on the program, have them see the dietitians, maybe see the psychologist. If you have an exercise physiologist, it would be helpful. Get them back into a better frame of mind, a better lifestyle, better diet. The next rung of the ladder would be commercial diet programs, which are more aggressive than just telling the patient to go on your own diet. Pharmacology, the next step could be endoscopic, as we're seeing more and more of the gastroenterologists developing these skills to plicate a pouch or tighten up an anastomosis, and when appropriate, revisional surgery or conversional surgery. I'm not going to discuss any particular medication for weight loss, as it's not my expertise, but some rules of the road that I've learned is, first of all, there's no hurry, take your time, be patient, put a patient on a medication, give it several months to see if there's an effect. If there isn't, increase the dose and watch them several more months. And then if that doesn't work, you could consider an alternative medication. We talked about antidepressants, so you screen for depression, as well as other medications that may induce weight gain. And also always consider, again, another trial of diet, exercise, and lifestyle alteration. Now, if your patient had a sleeve gastrectomy, I believe that operation, compared to the others, has the most options available for conversion to something else. You can re-sleeve the sleeve, but you can also, you can plicate it endoscopically, but also it's very amenable to a conversion to either a one anastomosis bypass or a roux bypass. It's a setup for a duodenal switch. In fact, that's, as you know, where the sleeve came from. And then it can also be converted into one of what I call the alphabet operations, such as the SADS, because they all have initials now. Re-sleeving the sleeve, my own experience hasn't been that good with it. I think it's best for ginormous pouches and ginormous sleeves. But in this study by Philip, they looked at 27 patients. And at the end of the day, they had a mean weight loss of 85% of excess weight, which is quite good. Converting a sleeve to a roux gastric bypass. What's interesting about this study was very few patients were done for weight gain. Most of them were done for symptoms. But the median percent excess weight loss afterwards was 32.7%. Although I acknowledge for 28 patients, they had a fair number of complications. So keep that in mind. This is not my experience. I have not had, or my group has not had that many complications with conversions. And again, as I mentioned before, you can convert a sleeve to a SADS or pick your choice of the alphabet operations. They seem to go fairly well. Now, what if you still have one of the few patients left in the world that has an indwelling laparoscopic adjustable gastric band? You can remove the band, convert the pouch to a sleeve or a gastric bypass or duodenal switch. Or you could even leave the band in place and still create a bypass. So some people have done that, or added a laparoscopic adjustable gastric band to a gastric bypass pouch. And there have been some promising studies with that, although I don't think it really is going anywhere at this point. What about converting a band to a roux gastric bypass? This is data from my own program. We have now way in excess of 94 patients. We have had very few problems, and very few of them that had to be done in 2 stages. As expected, if you split the surgery up into 2 stages, you'll have a longer operating time. Excuse me, if you do it in 1 stage, you'll have a longer operating time. But overall, the results were pretty comparable. And gastric bypass, whether it's a roux or a one anastomosis, they can be tightened endoscopically with plication. You can go and redo the bypass by redoing both anastomoses and making the pouch smaller. I think that has a pretty high complication rate, and I got into limb distalization, which is making the bypass a bit more malabsorptive by moving the lower anastomosis distally. But you got to be very careful in patient selection and also in how far you move the limbs because of the fear of malnutrition. Now, I have seen a paper or two about converting a gastric bypass to a sleeve. I'm not in favor of that, and I think we'll leave it at that. We're seeing more and more endoscopic primary surgery and endoscopic revisional surgery. We don't have long-term data, and the weight loss tends to be a bit more modest than what we would accomplish surgically, but it does save the patient an operation. Some cases, the patient may not be a good candidate for surgery, so this is a very good alternative to have and a good option to have in your pocket when you are evaluating a patient who's put weight back on. All same can be said for pouch trimming, which can be accomplished laparoscopically, where you go in and you try to amputate a redundant part of the pouch. In this study by Muller, I point out that there were 5 patients and 2 complications, but I think for those who do a fair number of these, the complication rate isn't 2 out of 5. And surgical anastomotic narrowing, I have concerns about taking down perfectly good anastomoses, because I think the redo anastomosis always has a much higher risk of complications, particularly leak. So I would much rather do something different, such as distalization. But there are people who feel strongly about going in, taking a bypass, taking it apart and putting it back together and hoping that it works out. Limb distalization, you can do it 2 ways. You could either lengthen the roux limb at the expense of the common channel and keep the biliopancreatic limb the same, or the style that I learned, which I'll attribute to Jacques Hippens of Belgium, which is to disconnect the roux limb off of the BP limb, bring the roux limb further down, keep the roux limb the same length, but enlarge the length of the biliopancreatic limb at the expense of the common channel. And this is data from my own program. We probably have done close to 30 patients. And I have to say, we have picked up several more severe nutritional issues. I think I might have been making the common channel a little too short. But the point I want to bring out is these patients were counseled, I don't know how many times, about eating and taking vitamins. And all of the ones who got into trouble all said the same thing. They stopped taking their vitamins. And that was really, for me, very personally hurtful because of the time I spent with them and the rest of my program, so that that wouldn't happen. So I think this is still the way to go because it's operatively very safe, but I think we still have a bit to learn about picking the right patient and making the limb lengths appropriately. So in conclusion, while anatomic derangements and poor compliance are part of the reason patients regain weight after bariatric surgery, the human body is also programmed to return to that preoperative weight. Therefore, good candidates can and will fail good operations. Understanding the physiology may help us in the future develop programs to better combat this so that patients do hold on to success either permanently or at least much longer than they currently do. And with that, I once again want to thank my hosts for allowing me to speak today. I hope that people found my talk to be interesting and wasn't too disorganized. And thank you very much.
Scott, thank you so much for a really, really interesting talk. And we asked you to pick a controversial topic, and I think you've done a great job. So a few questions have come in.
Yes.
So me and Vinod will take it in turns to ask you the questions. Can I just ask you to stop sharing your screen?
You got it.
Fantastic. Thank you so much. Okay, so let me start off. So should we regard weight regain as a failure and label it as such? Or something to be expected? And how do we counsel and consent patients regarding this topic of weight regain? Should we just tell them all to expect it because they're going to get it regardless?
Well, that's a very good question. And first of all, not every patient is going to regain weight. Although if you do notice, there's a little bit of an uptick for most patients when they reach that nadir weight, their lowest weight, and I'll give them up to 10% and call it just normal physiology, but I don't want to see it go beyond that. I think we need to tell patients that there's a likelihood they can gain weight after surgery, that they will be able to eat more, and that it's up to them to minimize that as best they can so they can counteract their own physiology with good activities. I mean, I'm in clinic today. I just saw a gentleman, he walks 5 miles a day. Well, that's going to offset whatever physiology he has to put the weight back on if he's walking 5 miles every day and watching what he eats. So I think we can use it to our advantage, but we have to be able to express those points to patients.
Thank you, Scott. Thank you for a fantastic presentation. And I particularly liked that analogy of a thermostat trying to self-regulate, the body trying to regulate to a preset weight. I mean, what are your thoughts on, I mean, if you talk to people like Malphobi and Mohit Bhandari, they talk about banding a sleeve and banding a bypass as a prophylactic measure to lessen the impact of weight regain. What are your thoughts on that?
I think that it works, but it works at the expense of patient discomfort. More patients who have it have dysphagia. They're basically suffering, and it's as if the lap band was tightened way too much. Yeah, you'll lose weight, but you're not going to be eating solid foods for a while. And when you do eat solid foods, you can't eat the foods you want to eat. So I'm not in favor of it. And I know the data, they do get better weight loss, but at what price? Here's what I think is going to be the future, and it's going to take care of this. There are conditions that patients have surgery, such as heart surgery or vascular surgery or orthopedic surgery, where they routinely go home on a medication for whatever the reason. I think what we're going to see in the future is all patients with bariatric surgery will be discharged on one of the anti-appetite medications, and whether it's going to be for a period of time versus permanent, that I don't know. But I think that may be the answer to some of this is to take care of it from a multimodal approach. You do diet, you do behavior, you do an operation, and then you put them on some type of medication.
Scott, I'll ask you a question from the Q&A. In terms of the role of gut hormones, and we know that, well, what do you think they will play a significant role in revisional procedures to the same degree as a primary procedure?
That I have no answer for. I guess it'll depend physiologically on whether the revisional procedure resembles the primary. For instance, if GLP-1 is created in the distal ileum, your revisional procedure should have just as much distal ileum as the primary to get the same effect. So there could be a difference in effects based on the length of the bowel or the ability of the bowel to produce these hormones. Same thing with the ghrelin. If you take out more stomach because you re-sleeve the sleeve, you may drop the ghrelin levels lower than if you did a primary sleeve with a bit bigger sleeve. But I don't know the answer. That's a great question.
Scott, there's another question from one of our psychology colleagues. I mean, if weight gain is inevitable, would it be beneficial to monitor the patient for longer than the 2 years, which is the mandatory period in the UK? And if you're excluded anatomical abnormality, what is the role for psychological preparation ahead of possible revisional surgery for weight regain?
All right, well, I'll try to remember all of those questions. First of all, I think there is a role because it's not just the anatomical changes that affect eating. It's a lot of things, including behavior. Patients that are binge eaters, patients that make bad choices. There's a lot of role for psychologists. We used to call it mindful eating in my program, that we would hope patients would think about chewing slowly, using, say, children's utensils, all different ways to slow down, even using the watch, the stopwatch, to say, I'm going to take a couple of minutes before I swallow and take the next bite. And the other thing you asked me, the first part of that was, what's that again? I can't hear you.
Longer than 2 years, a longer.
Oh, yes. In the programs I worked, and the program I'm at now, our follow-up is forever. Now, it may be 2 years for credentialing purposes, but we all continue to see people as long as they're willing to come back. I always give them a follow-up appointment. And, you know, it does become burdensome on the program to have so many follow-ups. Possibly the solution might be to better train the primary care doc, so when the patients go back to them, or it's like seeing us for our bariatric overhaul and evaluation. But they need to be seen more than 2 years would be my opinion.
Scott, a couple of questions. At what level of weight regain would you offer revisional surgery? Do you wait until they have regained most of the weight that they've lost, or do you hit them hard and early? Or what are your red flags for saying no, you can't have another procedure?
Another great question. First of all, the non-compliant patients are not going to get another procedure, so they're out altogether. As far as everybody else, I don't think that there's a set amount of weight that would trigger a response such as revision. I think it's going to be case by case, patient by patient. So let me give you an example. You have one patient who weighs 100 kilos. They have surgery, they lose 15, 20 kilos. They come back, they put 10 back on, but they're healthy. They have no comorbid conditions. Quality of life is good. Maybe that's the patient you just monitor and keep them from gaining any more, but you don't operate on them solely because they put on, 15, 20 kilos. Maybe there's another patient who put on 15 kilos and now they're back on insulin and they're back on a CPAP machine at night. That patient you may want to get to earlier because they're showing you signs that it's going to be problems with other, or with the metabolic issues that the first example didn't have. And I think lastly, it's got to be a patient who's tried diet and exercise, who's tried medication, maybe even was evaluated by the endoscopist, and there were no other solutions that worked. So I'm giving a long-winded answer, but I think it depends on the particular patients.
Scott, there's a question on role of hormonal assay before offering revisional surgery for weight regain in the future.
I have no experience with it. I would wait and see how it turns out, but I think if nothing else, it should be studied.
Okay. And a follow-on from that, I don't want you to mention any specific medications, but just in general, the role of pharmacotherapy in managing these patients. I mean, you alluded it to a little bit that you try them on particular medication, up the dose, wait a bit, don't rush. So
right.
I get that, but do you see that this is the future, that actually now that medications are coming online, very good medications, that any patient with weight regain should go through that process with meds before they are considered for a further procedure?
I believe that's the case. I think you're absolutely right. I think the patients need to also be, once again, given a refresher course on proper eating by the dietitian, be seen by the behavioral therapist to make sure there's no other factors that may have been responsible for weight gain. And then I think medication is perfectly reasonable to try. There will be patients who can't have medications. There'll be contraindications, whether it's because of other medications they're on or issues that they have. But I don't see any harm in a patient trying a medication for a year before they have revisional surgery.
Scott, it's a question from one of our surgical colleagues. You mentioned about limb distalization after previous gastric bypass. Any comments on the length of the common channel?
I think it's got to be at least 200 to 300. I think 300 centimeters is about what the Saudi people are suggesting. I was doing it smaller than that at one time, following someone else's recommendations. And then over time, I started to lengthen it a bit because I saw that I was having some problems with nutrition. So I think 300, but you know what? You got to measure the whole bowel, because if the bowel is 400 centimeters in total length, and I've seen that, 300 centimeters is too much. If the bowel is 1,100 centimeters long, then 300 may not be enough. And there's probably plenty of room to study the bowel to see if we can come up scientifically with the precise measurements. Some groups will do, would they do 40%, 40%, and 20%? And I wonder if that makes more sense.
Okay, we've had a few messages from psychologists that are listening to the webinar. So a lot have enjoyed the talk and find it really, really useful. Any tips for how, number one, we can improve patient engagement in our bariatric programs? And number two, should the patients who display weight regain, significant weight regain, have extra psychology input and extra resource, even if that resource is limited? What importance do you place on it?
Okay, the first question is, how can we engage the patients? And that's having a vigorous program with activities. We have a patient-only page on Facebook that they can go on and do whatever they want. We don't have access to it other than, I think one person in my program needs to just look at it to make sure that nothing's coming out of it that's not correct. But the bottom line is it's patient-run, patient-generated, patient-regulated. So that's their private place for voice. In addition, we have Twitter and Facebook pages, et cetera, where patients can be public. We've had in the past cooking demonstrations where one of the dietitians would bring in a little hot pot and a bunch of vegetables and start to show patients about proper cooking to make proper meals. We've had clothing swaps where patients who have lost a lot of weight would give clothing they had that they wore when they were larger to patients who were newer to the program who can wear it. So you could let your imagination run. We have, it's called the Bariatric Forum. We have it once a month, and there's a different topic. Some nights are open mic nights where the surgeon goes and just fields questions from the patients. You got to do things that patients are going to want to come in for or get online for. You can't do things that are going to bore them. So you have to be creative. And as far as the second question, for those patients who need revision, yeah, there will be some that probably would benefit greatly from having a bit more psychological support, behavioral support. And there may be others who have had the sleeve was made poorly to begin with, it was too large. That patient has an anatomic problem that no amount of behavioral therapy is going to help them. They need to have that pouch addressed.
Scott, thank you so much. We're coming to the end. We've literally got a couple of minutes left on the webinar, and you've done brilliant with the questioning. I've got one last question for you.
All right.
That David actually wanted to ask you, but he's not been able to rejoin. So what's your view on the role of combined surgery and pharmacotherapy? So we use it from the outset to get to, in the hope of getting there.
Very clearly, everybody gets psychological support, and even if they, I mean, he talked about that.
Thank you, David. If you can mute. So can we go back to Scott? Scott.
Well, I think I mentioned it, that in the future, I think that's going to be the way we practice, that everybody leaves here with, we give them a little goodie bag when they leave that has, protein shakes and a few other little things in it to kind of make them feel more festive. And in addition to that, we could be sending them home on something to reduce appetite or increase energy expenditure. And the issue would be, do we keep them on it for, say, 6 months and stop it, or do we keep them on it permanently? But I think that's the future.
Fantastic. Lovely, succinct, and straight to the point. It's been an absolute honor and pleasure having you. And thank you ever so much for supporting the webinar program that BOMSS is running. So time marches on, okay? So we look forward to seeing you in Oxford.
Same here. Same here. Thank you very much.
And I'll just mention that our next educational event is on the 14th of April. So that's the second Wednesday in April. And the team at UCL London will be running the Journal Club. So I hope as many of you can join us as we can. But once again, from BOMSS Council and the attendees, thank you ever so much, Scott.
My pleasure, and go BOMSS.
Yeah. Thanks, Scott. Fantastic. Thank you.
My pleasure. Have a good evening, everybody. And thank you again. I look forward to seeing you.
Thank you.
Thank you. Bye.